Rahim. I would like first to thank Professor Ahmad for inviting me to be a part of this important ISN courses. And as he told me, it is not the first time to be done in Egypt. It was done several times before. And it's really my pleasure and honor to be a part of this course this time. I am Professor Yasser AbdelHamid, Professor of Nephrology and Internal Medicine, Cairo University, Egypt. As some of you may know, I am interested in critical care nephrology and acute kidney injury. And in the coming few minutes, I will try to illustrate some important points that I met during my clinical practice regarding this important field of nephrology and everyday practice we met in ICU care of our patients. First, how to assess volume status, and these are the measures to assess volume status, clinical symptoms and signs of volume overload and of volume depletion. You all know. Chest X-ray, doing searching for curly B lines of volume of congestion. Natriuretic peptide pro-PNP, which are good negative tests, and if they are positive, they need a combination of other symptoms and signs to judge that this patient is having myocardial stretch of heart failure or volume overload. The point that I want to stress is the chest ultrasound detecting the B lines, same B lines of chest X-ray. Same B lines detected in chest X-ray can be detected by bedside use of ultrasonography without the need to transfer your patient to radiology department or doing the chest X-ray in bedside wise. Simply you can do it by ultrasonography machine, which is nowadays mostly present in our ICU care practice. Detecting P lines by chest ultrasound and also detecting IVC diameter. If it is increased diameter or normal diameter, and the collapsibility of IVC also is important. Is it collapsile or not? All of these signs and combining them with the use of chest ultrasound and the use of IVC diameter can judge that this patient is volume overloaded or not. And really, these two methods of using the ultrasonography machine bedside in detecting chest ultrasound and IVC diameter gave very useful tool to differentiate if the patient is congested or anything else, such as, for example, infection. While giving IV fluids, especially in patients with acute kidney injury, in sepsis, as in sepsis guidelines, please use dynamic measures, not static measures. Dynamic measures I use, on the top of them is response to passive leg raise or a fluid bolus. What is the response of CVP, jugular venous pressure, and hemodynamic parameters if you raise the leg of your patient for a while? And if you give your patient a fluid bolus. This is a very important item, clinical item that you can do bedside to see. If your patient is fluid depleted, you will see a small response or no response to raise or no response to passive raising, mostly no response to passive leg raising. If there is no response, if there is good response and the CVP increased after rising the leg of the patient or after giving a small bolus of IV fluids, this indicates that this patient is in no need for further fluid assessment and for further fluid intake. So please judge your patient after passive leg raise or after giving him a fluid bolus. Judge CVP and hemodynamic parameters. No more space now for static parameters, including CVP measurements alone. CVP measurements alone has no place nowadays. As most, for example, most of our patients having COPD, ascites, tricuspid regurg, all of these patients having false readings of high CVP, and you cannot judge. What about this CVP and what does it mean in case of this abnormalities? So please don't depend on single measurement of CVP in assessment of your patient. Coming to the second point is the diuretic therapy in acute compensated heart failure. This we use usually loop diuretics, and please remember that furosemide is 2-to-1 oral, as it have by 50% availability, while torsemide and bumetanide the same oral and IV doses as they are 100% available. Furosemide is affected by food, the same as bumetanide, while torsemide is not affected by food intake. IV response is a big response, but is of shorter duration, while oral response is much less than IV, but is of prolonged duration. And the dose needed in heart failure is more than the dose needed to attain the same response in patient with healthy persons. So, to induce further diuresis in cases of IV intake of diuretics, because of short duration, you need to inject more frequently or to give it as a continuous intravenous infusion after a bolus infusion. And this is the point I want to stress. Your patient will mostly respond to IV infusion if he responded to a bolus IV dose. So give your patient a bolus IV dose first. If he responded, this means that he will respond to IV infusion, go with IV infusion. If no response, it is questionable to respond to IV infusion for this patient. These are the oral doses. Please remember that maximum single dose in patient with normal kidney function is 80 for furosemide, and a higher dose is needed with impaired kidney function. Furosemide, bumetanide, torsemide are all excreted inside the lumen. We need a larger dose for these drugs to act in cases of impairment of eGFR, as they secreted inside, filter and act from within the lumen. So a higher dose is needed as glomerular filtration rate is impaired to attain the same effect. Torsemide 5 to 10 once in the morning, up to 200 milligram, while up to 2 milligram for bumetanide. For IV infusion, as I have said, inject a loading dose first to see the response. And this is the loading dose. 40, 1 for bumetanide and torsemide 20. And see the response. If good response, go to IV infusion. And in case of no serum creatinine more than 75, furosemide can be 10 milligram per hour, while bumetanide 0.5 and torsemide 5. If this decreases by 50, you need double the dose to attain the same effect. Higher doses are needed with impairment of kidney function, with impairment of GFR, as it is filtered, and with impairment of filtration, we need a higher dose to attain the same effect. With much more impairment, creatinine clearance less than 25, furosemide is increased, and the dose is more doubled. Doubled once, the 10 become 20, and then the 20 becomes 40. The 0.5 become 1, and the 1 become 2. Torsemide, for torsemide 5, 10, and 20. Another important point that I usually use in my practice, daily practice, is the adding of metolazone to IV infusion if there is no satisfactory response. Really, it is of great benefit for these drugs to give a diuretic effect. If you are not satisfied with your diuretic dose and for your patient with his response to your diuretic dose, add metolazone, 5 milligram daily according to these illustrations of infusion. If this is the dose of previous oral dose or previous infusion rate, if there is no response at this rate, at 10 milligram per hour, add 5. If there is no response to this is for furosemide, 20, add 50. Add 5 twice daily, and 30, add 5 twice daily. You will gain a more effect, and you will gain a better diuretic effect. For me, in my clinical practice, really, I use this if I have a diuretic resistance and if my patient is not responding well to IV infusion. And these are the doses to use according to previous IV infusion rate. My third point is heart failure treatment and the rise of serum creatinine. And this is an important dilemma. If we initiate diuretics and specifically RAS inhibitors in case of heart failure, they having the effect of decreasing interstitial pressure, decreasing ascites, increased tubular blood flow, and reduction of inflammation. All of these are beneficial to the kidneys and to the heart. These are important drugs for the heart. These are not just simply injurious to the kidney. In case of treatment of heart failure, diuretics, and specifically RAS inhibitors are important drugs, in spite of having the drawbacks of hypoperfusion and sympathetic nervous system activation with increase of serum creatinine. So this is a balance to treat the patient, and we are to get this benefit, we are to pay for rise of serum creatinine. But the good news that it is not an AKI, it is a worsening of renal function. It is called the worsening of renal function because of simply just the rise of serum creatinine. It is not a complete syndrome of AKI with its progression and the possibility of passing to chronic end stage. It is simply a chemical finding of rise of serum creatinine. It is defined as acute serum creatinine increase 0.3, GFR decreased by 25, which is equivalent to stage 1 right. And the question is having a prognostic sign or not. Fortunately, it is simply a rise of serum creatinine. Don't panic. It is not that that's complete syndrome of acute kidney injury, simply a rise. So deal with it smoothly to get the benefit for your patients. The prognosis depends on severity in cardiovascular duration and residual congestion. Congestion is injurious by itself. Congestion is injurious for the heart and for the kidney. We need to resolve this dilemma. Patient needs to be treated by diuretics and by RAS inhibitors to improve the myocardial condition and to improve the renal condition also. So pay for this by rising some rise of serum creatinine, needs a proper judgment to continue these drugs, not to stop rapidly if we find a rise of serum creatinine. This is simple algorithm for RAS inhibitor with acute kidney injury in case of RAS inhibitors. If the patient is volume overloaded, then all decompensated heart failure should receive diuretics. Receive diuretics first, decongestion with diuretics with high dose or infusion. In case of heart failure with reduced ejection fraction, consider reducing or withholding RAS inhibitors only if symptomatic hypotension or severe hypokalemia or progressive acute kidney injury. While preserved ejection fraction, you can stop RAS inhibitors as no prognostic benefit. In case of hypotension or infection, stop RAS if no other cause or no prognostic sign, such as heart failure with preserved ejection fraction. If no other cause for hypotension, you are to consider at this time stopping RAS. It is symptomatic hypotension or hyperkalemia or progressive AKI. The same, symptomatic or hyperkalemia, resistant to treatment or progressive AKI. These recommendations change in case of heart failure with preserved or reduced ejection fraction. Creatinine increase less than 30%. Preserved ejection fraction, consider stopping. Reduced, continue. From 30 to 50, stop if preserved ejection fraction. Residual, consider reducing the dose, not to stop if there is increased creatinine. Reduce the dose and see the effect. These are beneficial drugs. More than 50%, temporarily stop in case of heart failure with reduced ejection fraction and try to reinitiate again. Important drugs. You can stop completely in preserved ejection fraction. Of course, if there is GFR less than 20 or uremic symptoms, at this time we are to stop the drugs and not to go further as the patient, this is a progressive case of acute kidney injury. Thank you very much, and I hope I have stressed on some points that will be important for you in your clinical practice. Thank you very much.